Welcome to podcast 5.
I'm Fran,
And I'm Minnie.
and as usual, we'd love your feedback, so please do give it via the forum.
This podcast topic is primary hypertension. So our tip for today's podcast is check patients' blood pressure routinely, even when they've come with some other medical problem, as they may have asymptomatic hypertension.
And as with podcast 4, we thought we'd discuss a case to talk around the topic. So in this case, a 60-year-old male patient comes to see you about an unrelated illness, and on checking his blood pressure, you find it to be 160/90. He is a smoker. He drinks 2 bottles of beer each night and is overweight with a body mass index of 35. So a body mass index is their weight in kilograms divided by their meters, their height in meters squared. And this gives us an indication of whether somebody is overweight or not, because obviously taller people tend to weigh more.
Okay, so what are the normals, Fran?
So normal would be between 19 and 25, and we know that a high body mass index is linked to various illnesses, particularly diabetes, hypertension, cardiovascular disease, and even some cancers.
Okay, that leads us nicely to thinking about what do we mean by hypertension, high blood pressure. So this is a persistently raised arterial blood pressure above 140/90 millimeters of mercury. The top number, that's the amount of pressure in your arteries during contraction of your heart, and this is the systolic pressure. And the bottom number, that refers to your blood pressure when your heart muscle relaxes in between beats, and this is called the diastolic pressure.
And his high risk factors for hypertension include his age, so he's 60, his sex, so we know that males have a higher risk, so women at his age, so under 65, tend to have a lower blood pressure, but then it tends to increase between 65 and 74. Unfortunately, we know his ethnicity, that people of Afro-Caribbean descent tend to have high blood pressure. And also his lifestyle. He smokes, he's drinking too much alcohol, he's overweight. We don't really know about his diet or his physical activity, but those are things that we would ask.
Mm-hmm. Okay. We'd also ask, wouldn't we, Fran, about any family history, because primary hypertension can indeed run in families. And on questioning your patient, we found that his father had died from a cardiovascular attack, so a stroke, age 60. And actually, he's really worried that this is going to happen to him. And of course, anxiety and emotional stress can contribute to raised blood pressure.
Yeah.
So we would, having taken his blood pressure and talked to him about it, and we'd start talking around the topic of blood pressure, he might ask why he would need treatment if he feels fine in himself.
I think that's tricky, isn't it? Because actually, most patients with high blood pressure feel absolutely fine, don't they?
Yeah, they don't have any symptoms.
Yeah.
So obviously we need to address this question, don't we?
Yeah.
So more than 50% of heart attacks and strokes are actually associated with high blood pressure. So it's a sort of silent risk factor.
Yeah. So, and of course there are other illnesses as well. So I mean, obviously that's a huge number, Minnie. And I was really surprised when I researched around the topic that it was that high. But of course there are other illnesses as well, such as renal failure, kidney disease, and types of dementia that are also associated with linked even with high blood pressure.
Okay. So we need to check his blood pressure. How do we do that?
So we're going to check. Yeah, so we'd need to check his blood pressure in both arms, and if there is a difference in the readings between the two arms of more than 20 millimeters of mercury, we should be using the arm that has the higher reading, because we want to assess his highest risk and the highest blood pressure. And then we would make him sit. So ideally he would sit for 5 minutes, and you would take a total of 3 readings, each 5 minutes apart, and you would record the lowest reading.
Okay, so when your patient's sitting, you obviously want them to be comfortable, don't you? And support their back, support their arm that you're going to be taking the blood pressure in.
And you want it at the level of their heart, their arm at the level of their heart.
Okay. And the other important point is the size of the cuff. It needs to be the right size for the patient, because if they're very large and you use a small cuff, you'll get an erroneous high reading. So you may start someone on treatment with the wrong, when actually their blood pressure is normal. So a sort of guide would be that the bladder of the blood pressure cuff needs to be about 80%, come around the arm about 80%, so nearly all the way around the arm.
Fantastic.
And the width, so from between the shoulder and the elbow, it needs to cover about 40% of that, so almost half.
Brilliant. That's really helpful. And actually, in my setting, I tend to only have 2 blood pressure cuffs, one for normal sized people and then one for much larger patients, possibly such as this.
Yeah, I think I have a slight obsession about it, just because of working with children, and obviously children come in many numbers of different sizes, so it's really important that you get the right size.
Absolutely, that's what I was going to go on and say. But
sorry.
I think you're absolutely right, and so it's particularly important in children. So with this patient, with his blood pressure as it stands, I wouldn't start treatment straight away. Ideally, what I would want to know is what his blood pressure is like over time. So in the UK, we're very into home blood pressure monitoring, and we get patients to buy blood pressure machines and to record their blood pressure at home. But I appreciate that may not be possible in Zambia. So actually what you could do is you could bring him back to clinic, ideally another 2 times to check his blood pressure. And also those times you can use as an opportunity to do some further tests. So we'd be checking his urine, particularly for blood, to see if there was any damage to his kidney. You'd ideally want to check him for diabetes, and if you had access to his cholesterol as well, would be very helpful. You'd want to do a thorough cardiovascular examination, and if you felt confident, you would want to look in the back of his eyes to see if he had any signs of high blood pressure there. And again, if you had access to it, you would also want to do an ECG to see if there was any evidence of high blood pressure. So typically that would show left ventricular hypertrophy, which shows that he's had high blood pressure for a long time, and his left ventricular muscle has grown bigger because it's having to work much harder to pump the blood around his body.
Okay, so we were thinking that it would be quite a good idea for us to put some ECGs on the forum and discuss those, so that everyone becomes confident in looking at ECGs if they're able to do them. Yeah,
I think that's a great idea, Minnie. We can certainly do that.
So moving on, we're obviously working towards a diagnosis of high blood pressure, but we can give our patient, in the meantime, some quite helpful lifestyle advice to help him reduce his blood pressure without any need for medication, possibly. So this would involve giving him advice about stopping smoking, reducing his alcohol consumption, or maybe stopping it completely, because some people are extremely sensitive to alcohol in terms of their blood pressure, and just stopping alcohol can sometimes be all they need to do. Encourage him to take up more exercise, lose weight, and reduce his salt intake. So quite a number of things you can do to modify your risk.
Yeah, and I think, it obviously varies between how motivated a patient is, and some patients go off and really are very keen not to take medicines, and I've seen patients very, very motivated and have completely changed their lifestyles and lost a lot of weight, and other patients obviously aren't motivated in quite the same way.
Yes.
And so it sort of goes in one ear and out the other, unfortunately. But in this case, our patient returns 2 further times, and actually his blood pressure is consistently raised. The tests that we've done have been normal, and in fact we've diagnosed him with primary hypertension. So what is primary hypertension? That's high blood pressure that has no underlying cause, and that accounts for 90% of high blood pressure.
It's a lot, isn't it?
It is. So actually only a very small amount, 10%, is what we term secondary hypertension, which is hypertension due to an underlying cause such as kidney disease. And in fact, we'll do a podcast on that another time. And the other thing just to be mindful of is something called white coat hypertension, which is blood pressure that becomes unusually raised when it's measured by a clinician. And, we all have this. I know my blood pressure goes up when I go to see my GP. So in the UK, that's why we started doing much more home blood pressure readings, because it gives us a much more accurate assessment of what the patient's blood pressure is like when they're not in the medical setting.
In a threatening situation.
Yeah, exactly.
Okay, so we're going to start our patient on some medication as we've made this diagnosis, and there's a useful medication ladder that we can use, and the other thing to bear in mind is to take account of other illnesses. So if they've been on medication previously, they may have had side effects. You need to take into account their age, whether they are of childbearing age or things like that.
Fantastic. So in this population, so we would be starting with a calcium channel blocker. So that would be a medicine such as amlodipine. Typically, I start at 5 milligrams because 10 milligrams very classically gives ankle swelling to patients, which they don't tend to tolerate. My next medication to add in would ideally be an ARB, such as losartan, or an ACE inhibitor, such as lisinopril. Now, there's a lot of evidence that Afro-Caribbean population don't respond very well to ACE inhibitors, which is why we don't tend to use them as a first-line medicine for this patient, for this ethnic group. Third line would be a thiazide-like diuretic, something like hydrochlorothiazide. And then fourth, it becomes a bit more tricky here, because obviously these are patients with very difficult to control blood pressure. So you could consider adding in something like spironolactone at a dose of 25 milligrams, or a higher dose diuretic. But with both of these, really, in an ideal world, you want to be measuring their potassium, because it can cause high potassium, which is obviously dangerous.
So just to clarify, Fran, this ladder we're adding in, so it's in addition. So
absolutely,
by this stage, the patient is on 4 drugs.
Exactly. So it's really common, if somebody has high blood pressure, that they will need more than one medicine. And if their blood pressure doesn't change, it doesn't mean that medicine isn't working. It just means they need an additional one. So yes, it's not a question of stopping and starting. Thank you, Minnie. Yeah. Okay. And then finally, as a fourth line one, it would be adding in a beta blocker. But traditionally, we don't no longer use those just for blood pressure.
Right.
So by that point, if it's still not controlled, or if the patient isn't tolerating the medicines, really you need to be seeking expert advice, and you're obviously very welcome to use the virtual doctor system to do that.
Fantastic. So once we've started our medication for our patient, we need to see them again in about 4 weeks, but we need to leave it at that long so that the treatment can actually work, because it takes time to gradually reduce the blood pressure, and we don't want to be adding in those other medications too soon. And we're aiming for a target blood pressure below 140/90 millimeters of mercury in people who are under 80, and in the over 80 population, they're allowed to have a slightly higher normal blood pressure of 150/90.
Yeah, and that's because that population is very prone to falling, and also to having what's called postural hypotension. So when you measure their blood pressure in clinic, you may think it's high, but what happens is they stand up and their blood pressure drops quickly, which puts them at risk of falling, and then from that they're at risk of breaking hips and stuff. So
would it be worth checking their blood pressure standing as well then, Fran, when you see them in clinic?
I think that's a really good idea, and I quite often do that, yeah. So we start our patient on 5 milligrams of amlodipine, and when we next review him, his blood pressure has come down very nicely to 124/80 millimeters of mercury. So at this point, we don't need to review him again for another 12 months. Yeah, so we don't need to be seeing him every 3 months and checking. The guidance in the UK is that you just see them every 12 months, lifelong. Yeah, so he stays on medicine, and this is a lifelong review. And at that review, you will be reiterating the lifestyle advice. Keep trying to persuade him to diet, to exercise, to stop smoking and stuff. You'll be asking if he's having any symptoms, and if he's having any problems taking his medicines, including if he's having any side effects.
So would you at any point decide to take them off medication?
If his blood pressure was very low, so if for example, it was 110 over 60 and it had been like that a few times and he was keen to try and he'd made some lifestyle changes, then yes, I do sometimes give it a go. Yeah, absolutely. And again, conversely, if it's high, then we go back all the way back again and go, right, it's high again, let's check you over 2 or 3 visits, and then we'd go on the next step up the ladder. Right. And like you say, add in another drug, not swap it. But obviously being mindful that when we're adding in things like ARBs or ACE inhibitors, in an ideal world, we'd have access to checking the patient's renal function.
Okay. And the final thing to mention really is if a patient has a blood pressure, has severe hypertension, and they might often present with headaches but not always have symptoms. So that would be if their blood pressure was 180 over 110 or more, then you need to start your treatment immediately, and maybe consider admission depending on whether they did have any other symptoms.
Yeah, fantastic. I think that's really important. And again, my first line treatment would still be amlodipine, but then I might start 10 milligrams and risk the ankle swelling with someone like that.
Okay. Lovely. Well, that's the end of this podcast on primary hypertension. I hope you found it useful. Let us know if there are any other questions that arise from it on the forum. Many
thanks. Thank you so much. Bye.